My slides are visible, Rekha? Dr. Rekha, my slides are visible?
Yes, ma'am.
And I'm audible, right?
You are eligible. Yes. Yes.
Okay. So we'll be learning 3 things in the knee. How to go about doing an injection inside the suprapatellar recess. We will be learning about the jumper's knee, and then we will be learning about the housemaid's knee. So these are the 3 things we will be learning in the knee joint, and then we will be just learning the sonoanatomy of the nerves around the ankle joint. So these are the 2 things which we will be covering today. So when we say knee joint is a distal synovial articulation between this distal end of the femur and the upper end of the tibia. So it's a synovial articulation between the distal end of the femur and the upper end of the tibia. We do have an articulation between the femur and the patella. And we are going to call this articulation as patellofemoral joint. Fine. So this is a joint between femur and tibia, and we have a joint between femur and patella. Fine. We do have a joint between the tibia and the fibula as well, but it doesn't contribute in the formation of the knee joint. Then when you look at the surface of the patella, you are supposed to remember few things because they are very important. So when you are looking at the patella, so this is patella. How is the shape of the patella? It is something like this, how our bladder is in our body, right? So we are going to call this portion, okay? This will be the base of the patella, okay? And this pointed one is the apex of the patella. So this is the apex and this is the base. So base is up, apex is down. What is the importance of learning this is you have the insertion, okay, of quadriceps tendon on the base and you have the origin of the patellar tendon from the apex. So one is your insertion and the other one is the origin. Fine. Now, when you go to tibia, so this is tibia. What you need to remember here is this bumpy thing which is present on the anterior aspect of the tibia. And what is the name of this bumpy thing? The name of this bumpy thing is tibial tuberosity. Fine. So what is the take-home message from this slide? That you need to remember that base is the insertion for the quadriceps tendon. Though some fibers, they do run over it and they just get intermingled with the patellar tendon fibers. Fine. But you should remember this very, very nicely. And the other is the apex, origin for your patellar tendon. Then is the tibial tuberosity, which is the insertion for your patellar tendon. Fine. So patellar tendon is getting origin from the apex and it is inserting on the tibial tuberosity. Then you have your synovial membrane followed by the capsule. Now, what is the important thing which you should know about this synovial membrane is, as you can see in this picture, that there is a proximal extension of this synovial membrane. And the proximal extension of this synovial membrane only we are going to call it as suprapatellar recess. So what is suprapatellar recess if I'll ask you? So your answer should be suprapatellar recess is the proximal extension of the synovial membrane of the knee joint. And that's the reason whatever we will be injecting in this recess will be just going around the joint. Then we have this quadriceps tendon. Fine. So this quadriceps tendon, go with the name. So it is quadri, means there should be some 4 muscles which are really forming this tendon. So if you go from the lateral to the medial side, one thing which is common, that is the name, vastus. So this name is common for all these 3 muscles. So if you are on the lateral side, it becomes vastus lateralis. If you are on the medial side, it becomes vastus medialis. And if you are in between, we are going to call it as vastus intermedius. So we have lateralis, we have intermedius, and we have medialis. And on the top of this vastus intermedius, we have the rectus femoris, which is here. So this rectus femoris vastus lateralis, intermedius, and the medialis. 4 of them, they will combine to form a tendon. The name of this tendon is quadriceps tendon, which inserts itself on the base of the patella, and superficial fibers of this rectus femoris, they will be continuing down and they will be getting intermingled with the patellar tendon fibers. Fine. Now we do have another muscle, which is just an ignored muscle, but it is also very important muscle. This is articularis genu, because this muscle, it's take its origin from the anterior shaft of the humerus of femur, and it attaches itself on the suprapatellar recess. And that is the reason it will be preventing the suprapatellar recess to just go inside the knee joint when this muscle is contracting. So this is also one of the very important muscle which you should know. Now this, we are looking at the sagittal section of the knee joint. So here what you are supposed to remember here is we have 3 fat pads. Okay. So 3 fat pads, we have suprapatellar, prefemoral, and then infrapatellar. Fine. So suprapatellar means this is patella. Again, I say anatomy is very easy if you go by the name. So this is patella. Now this fat pad is superior to the patella. So this becomes suprapatellar. Now you have another fat pad which is here. This is like on the top of your femur. So it becomes prefemoral. So if you see suprapatellar and prefemoral fat pad, they are, when you are just looking at the patella, means they are from here till here, you will be seeing these 2 fat pads. But once you are seeing this patellar tendon, which I'll be showing you, beneath that you are having another fat pad. So the name of this fat pad is infrapatellar. So this is inferior to the patellar tendon. So it becomes infrapatellar fat pad, or we also call this as Hoffa fat pad, right? So 3 fat pads, suprapatellar, prefemoral, infrapatellar, right? Okay. So we were talking about the patellar tendon. So this should be the apex of the patella. So this patellar tendon take its origin not only from the apex, but from the side also, and it attaches itself on the tibial tuberosity, which we have already seen when we started the presentation. Now, on the top of this, in the subcutaneous plane, we have 2 bursas. One is prepatellar bursa. This is in the subcutaneous plane, exactly over the patella bone, okay, in the subcutaneous plane. So this should be present in the subcutaneous plane between what all 2 structures, your skin and the superficial fibers of the rectus femoris. Now, when you go little more down, you have superficial infrapatellar bursa. So this bursa is lying in the subcutaneous plane between the skin and the patellar tendon. Fine. Now, once you go down, you have deep infrapatellar bursa. So this bursa will be lying deep, like on the deeper aspect of the patellar tendon. So if I'll ask you, where is it located? It is located between the patellar tendon and the tibia. So make it very simple that you have a patellar tendon. Okay. So this is my patellar tendon. This is skin. Sorry. So this is skin. Then you have your subcutaneous tissue. This is my patellar tendon and this is tibia, right? Now, if I have a bursa here between the patellar tendon and the skin, it becomes superficial infrapatellar bursa. If I have a bursa between the patellar tendon and the tibia, this becomes deep infrapatellar bursa. Fine. So all this we will be seeing today. Now, if you have any doubts, you can ask me. We will be discussing the pathology in a while. Mali. Okay. So now, when you are scanning knee, what is the most important thing is the position, right? So you should always examine the knee in the supine posture, right? There are so many other dynamic maneuvers where nowadays we are examining the knee in the sitting posture also. But for your basic course, remember that whenever you are examining knee, patient should be lying down in the supine posture, and you should keep something beneath the knee joint. You can keep a rolled sheath, or you can just keep a rolled, pillow also beneath the knee joint. Why is it important? Because we want to have this knee flex approximately to 30°. Why this is important? It is because you have your quadriceps tendon, which is coming from here, okay? And it attaches itself on the base of this patella. So if I am going to stretch this tendon, how can I stretch it? By flexing the knee. So when I am flexing the knee, I am basically stretching the quadriceps tendon, so that I am just eliminating the anisotropy, right? And I'm not letting it sag down when I'm examining it, so that I might get, misleaded that, there is some pathology and which is there, but in real sense, it is not there. It is because of the positioning, you are able to see some pathology in the quadriceps tendon. Fine. Now, before going into the demonstration, remember that the palpatory things which I always see in all my classes, that this is the patella. We have learned that the base is up, so this should be the base of the patella. And if I will bring two of my fingers, they will be just meeting at one point. So this point should be the apex of the patella. And if I go down, I'll meet some bumpy thing here. This is the tibial tuberosity. Fine. So means my quadriceps, my vastus lateralis is here, intermedius is here. On the top of intermedius, I have my rectus femoris, and on the lateral side, I have my vastus lateralis. Four of them, they will combine to form a tendon. So this tendon will be here, and it attaches itself on the base of the patella. Some fibers, they will be coming down over the patella, and they will be getting intermingled with the patellar tendon. So patellar tendon is from this apex, and it goes up to the tibial tuberosity. Fine. So let us see. How are we gonna see it? Today, I'm using a frequency of 12 megahertz. Ankle, we will use 20 because knee is a deeper structure. So, okay. So what you are supposed to do, now this is your quadriceps tendon, fine. You put your probe in the longitudinal axis with the SPIC marker towards the patient, because now he's lying down, not patient, volunteer, okay? And you palpate the patella. Keep one of the finger there and just put the caudal end. So this is the cranial end where the SPIC marker is, and this is the caudal end. So what I'm going to do, I will just put the caudal end here, right? So the moment I am going to do this, I will be seeing something like this. I can make it look better, and I will freeze it here. So what are we seeing here? Since this was the cranial, okay, let me switch on the annotations. So this was the cranial side, and this is the caudal side. That is how my probe was. I was looking at the sagittal section of the quadriceps tendon. So where I kept my probe? I kept my probe over the patella. So this is patella. Now this bone which you are seeing here, that is the femur. And just a second. Sorry. So this is femur and this is your patella. So what are we seeing here? We are seeing this is the skin. This is your subcutaneous layer. This whole what you are seeing here, that is your quadriceps tendon. Okay. Now what you are seeing here, that is your suprapatellar fat pad. And what you are seeing here is the articularis genu muscle, and this is your prefemoral fat pad. Now the black thing which you are seeing here, like this is your suprapatellar recess. Okay. So this is the sagittal section. You will be seeing all the structures which we have learned. So once you have seen the sagittal section, we will be looking at the axial section now. So for axial section, what I have taught you is we always look for the longitudinal axis like this, and then we rotate our probe. Fine. So once we are rotating our probe, we will be able to see the same thing which we have seen, right? So let me freeze it here. So what all we were seeing? This is femur. Now this is your suprapatellar fat pad. This is your quadriceps tendon. This is your prefemoral fat pad. This is your articularis genu. And what you are seeing here, this one is your suprapatellar recess, right? So we have seen the same thing in the longitudinal axis. The moment you see it in the longitudinal axis, you rotate your probe and you will be getting exactly the same thing which you are seeing there. So that was about the suprapatellar recess. Now what we will do? So our probe was like this in the longitudinal axis, right? And we have seen all these structures. Now you slide your probe to just over the patella. So once you are sliding, so we were here, the caudal end was exactly over the base of the patella. We slided it over the patella. So once you are sliding it over the patella, we have learned that this is the patella which you are seeing. They are the superficial fibers of the rectus femoris which is going. And this is your skin. Okay. And the subcutaneous tissue, a very thin layer is there. So if you happen to see a bursa here, and usually these patients which we will be discussing, they will be coming with the pain over the patella. So in that condition, you will be able to see a collection there. But now he is a volunteer. He doesn't have anything. So we are not able to see anything there. So you look for any kind of collection there. And that time you keep the pressure of the probe very minimal. So once you have identified that, again, we will slide our probe down. So we were here like this, caudal end over the base of the patella. See, you can nicely see the demarcation between the prefemoral fat pad and the articularis genu. Then we have slided it over the patella. And now I will be coming down. So from here, I will be just coming down. Okay, let me have some jelly. Right? So what are we seeing? Now, this is the apex of the patella, which you are seeing. And that is the patellar tendon, which is going. This is the fat pad. Once you have seen that, you keep on coming down. Don't stop the moment you see the tibia started coming up, because this is not our point of interest. Our point of interest is the tibial tuberosity. So you need to just toggle your probe, look at this fibrillar pattern. Okay. And you keep on going down, down, down until you see the insertion of it like this. Okay. So here you are able to see the insertion, and that is the tibial tuberosity. So you need to keep on going up, up, up. Okay. So let me come out of this mode and I will show you how exactly we have gone. Okay. So this is a panoramic view. I hope it is now nicely seen. So this is how you are supposed to evaluate, right? From the patellar tendon, from the apex of the patella, this is the tibia which has started appearing, and this is what is the tibial tuberosity. So you are supposed to identify this whole patellar tendon there. This is your fat pad. What is the name of this fat pad? That was Hoffa fat pad. Right? Now, here one important thing which you should note here is, if you are seeing a bursa here in this subcutaneous plane, right? So this becomes the superficial infrapatellar bursa. Now, we are already seeing a collection here. So this is physiological. So this is your deep infrapatellar bursa. And as you can see, this is between the patellar tendon and your tibia. And if it is in the superficial aspect somewhere here, this will be between the patellar tendon in the subcutaneous plane between the skin and the patellar tendon. So this will be your superficial infrapatellar bursa. And once you have identified this tendon in the long axis, so we have identified like this, right? So again, what you are supposed to do, you rotate your probe. So now we are looking at the short axis. So you need to evaluate this tendon fully. So this is how the tendon is in the short axis, hyperechoic cluster dot-like appearance. Fine. So that's all in the demonstration for the knee. Now, any doubts if you have, you can ask me, or we will just discuss the pathologies. Any doubts? Okay, then let's discuss the pathologies. So the very first thing is osteoarthritis. Okay. So for our osteoarthritis, what exactly do we mean by this is a degenerative and a progressive joint disease. And how will be the presentation of the patients who are suffering from the osteoarthritis of the knee? It is most commonly seen in the middle-aged female. She will be complaining to you that I'm not able to sit on the floor with the crossed legs. And if I'm sitting on the floor, if I have to get up, I just make use of my hands and I just take their support and then I am able to get up from the floor. She might be complaining you that I'm finding it so difficult to climb the stairs up and down. And I need to, and some of the patients, they will be walking with a stick as it is shown in the picture. And some of them, they might be complaining to you of night pain. They might be complaining to you of burning sensation as well. Why burning sensation? Because any pain, if it is there for a long time, patients develop sensitization. So what is sensitization? Is an inappropriate response to your stimulus, right? So all these are the characteristics of the chronic pain. So now this pain means your acute pain has become now chronic. So this are the presentations of the chronic pain. Don't think that burning sensation, how is it possible? Many of my patients in my practice, I have seen them complaining of burning sensation, right? So these are basically more or less the features of like the symptoms of the osteoarthritis, which you will be seeing. Now, if you examine, obviously there'll be a medial joint line tenderness, because the medial aspect is the more commonly involved as compared to the lateral one. And there'll be difficulty in the flexion and the extension of the joint. So these are more or less the presentation of it. Now, what are you supposed to do? You will order an X-ray. So that, especially knee X-ray, you should know, because if you take the back pain, that is the most common presentation, commonest, I should say. Your patients will be presenting to you in your clinic, and then followed by shoulder and knee. So you should definitely know how to read the X-ray of knee. And because shoulder, basically for glenohumeral arthritis is not that common as compared to the tendinopathies. Fine. So now, if you see this X-ray, just I have drawn it so that you are able to understand. This is your patella. Fine. You have your condyles here, right? As seen there. Now, this is your medial plateau, and that is your lateral plateau. These are the tibial spines. Don't think they are the osteophytes. These are tibial spines. That is your tibia and that is your fibula. Fine. This is your joint space. So more or less, this is a normal X-ray which you are seeing. Now, what if, you are having a problem? Then it starts looking like this. Okay. Now you see what you are seeing here. They are the projections from this bone itself. So they are osteophytes. And how beautiful joint, this line we have seen. Now you go to this, it has started becoming narrow. Okay. And here you are able to see something like this, right? So they are tibial spiking. They are tibial spines like this, but once they become rounded here, they are tibial spiking. You do see the irregularities here. Fine. So these are the features of your, I should say, the osteoarthritis, okay, which you see on the X-ray. Now, if you want to learn the grading, you can take the screenshot of this, okay. So these are the various grades, and we usually follow this Kellgren-Lawrence classification, and I have written the grades also of this classification. So briefly, I will just tell you, okay, because you can just go back and read all this, that once you are looking at this joint, okay, the more bad the knee is, as I have told you, medial side will be the one which will be most commonly involved as compared to your lateral side. So you just try to look for this medial side, and you will see that you will be able to, it's just an observational thing. So you will be able to see how bad your knee is, right? How your joint space narrowing is there, whether you are able to see some kind of osteophytes, whether there is any kind of sclerosis like this, okay, which is there or not. So on the base of all this, you will be able to classify it into grade 1, 2, and 3, and 4. So 4 is the worst. This is third. This is second, and this is worst. Now, if a patient who has come to you and is having OA knee, the first thing is you have to you have to tell your patients, if it happens to be an obese individual, then you have to tell your patients to reduce the weight. Okay. Tell them that we are not doing a body shaming. Okay. This holds on very important, I should say, an important aspect which needs to be taken care when it comes to osteoarthritis knee treatment modalities. Okay. Tell them that this line, okay, that 10% risk reduction of knee OA per kilogram of body weight decreased. And this is a scientific study, just like that, we are not saying it. So if she's going to reduce the weight, she's going to reduce the load which her or his knee, they are just going through. Tell them this. And these are all scientifically proven things, okay, just like that, we are not talking. So do tell them to reduce the weight. This is very, very important. Then comes the society's recommendation. Don't just like that write any drug and follow because I am asking you to do so. No, you should follow the guidelines always whenever it is possible, right? So when it comes to osteoarthritis, they have got a good role. As you can see, I talked about obesity, and it has got a very good recommendation from all the societies. They are the standard societies which we follow when it comes to osteoarthritis. Then some people will be coming to you to sell these two drugs, okay, chondroitin and glucosamine. Very often they will come to you that, this will be increasing I should say, the cartilage of the knee. This will be helping. They will have their own bias studies. Don't go by that. If you go by the society, there is no recommendation of these products. So do not prescribe these products to your patients. Second thing, you can go for, paracetamol. You can give duloxetine also. As I have told you, they do not have a recommendation, but still we have a recommendation from OARSI, right? Duloxetine usually for the chronic pain, when the patient is complaining to you of burning sensation, right? So that time it should come to your mind that this patient might be just going through that sensitization part of the chronic pain, and no, nothing will be able to heal that other than these neuropathic medication. And out of that medication also, we have a recommendation only and only for duloxetine, okay? And do not give, I should say, the amitriptyline to this older male patient especially. They will have, this is going to aggravate their prostate problem, okay? Do keep this thing in mind. These are very small things which we do not read, but they are equally important. then you can give oral or the topical NSAIDs. If you go for this opioids, supposedly there is a cardiac patient, you don't want to go for an NSAIDs, you can give opioid also, but for a shorter time, and it does have a recommendation from AAOS. Steroids, yes, it's a mixture of, I should say, the recommendation and this intra-articular viscosupplementation, that is hyaluronic acids now so much in the market. But these societies, they do not give a recommendation for it, but there are RCTs which are coming up. When we say RCTs, they are the randomized control trial, and they are really very helpful for us to understand something, right? So RCTs are there in favor of HA. So, but still it is just an off-label use, right? It is not there by, into the recommendation, but still RCTs are there. So if you want to go ahead with HA, that is hyaluronic acid, that also you can go for. Corticosteroids, recently you can read all these studies. They are against, you know, giving the steroid inside the joint, because this is gonna cause the destruction of the chondrocytes, right? And really making this pair, like even in the grade 1, grade 2 you are giving. So it is basically shortening their time period to go for the TKR, right? It is going to cause a destruction very badly. So don't inject steroid inside the joint. Second important thing about the HA, that is the hyaluronic acid. This is present in our synovial fluid, okay, with a molecular weight of this and in a concentration of this. Now, there are 3 varieties of hyaluronic acid available in the market. This, fine. And this is the one which is just lubricating our joint. This is how you can remember. There are 3 varieties of it, and these are all the in vitro studies. They have proved the effect of this HA, that is, they are chondroprotective, anti-inflammatory. They also increases the synthesis of this proteoglycans and the proteoamino acids. They have got an analgesic potential also. So these are all proved by the studies. Now, whenever you want to go for an hyaluronic acid, just remember this chart. This is very, very important, right? This hyaluronic acid, there are so many brands. Whatever you want to use, you please use. There is no objection in that. Just look for only 3 things. 1, what is the source of preparation? That whether it is from a bird source or it is from a bacteria. Because from a bird source, you are going to get more amount of allergic reactions. But it is from a bacterial fermented source, the chances of allergy is going to be less. Second thing, ask them whether it is a cross-link or not, because this will be more effective. This is not going to degrade very easily if it is cross-linked. Third thing is, what is the molecular weight? Always go for the high molecular weight. Like what I am using right now is 30 mg per ml, and I give 3 ml. Okay, so it becomes 90 mg. So that is the amount which I am using right now, and it is a cross-link and bacterial fermented. So this is how you can choose. It is all up to you. But these 3 factors are very, very important. Molecular weight, your linear chain or cross-linked, and third one is what exactly is the source, right? Now, here I will show you a picture. This is not a picture, a video, okay? Just the fluid inside the suprapatellar recess. So see, if you happen to see such a big, such a massive fluid inside the joint, do not just think it is an osteoarthritis, even though you are dealing with a patient, old patient. So this patient had a severe meniscus tear, okay? And later on, we ordered the MRI and we could see very nice bucket handle tear of the meniscus was there. Second thing, whenever you are looking at the fluid, so this is again a video. So if it's just a simple fluid, because in the recess, you can have a synovial hypertrophy or you can have just a simple fluid. So if it is a simple fluid, it is compressible, okay? And you will be able to displace it. But if it's a synovial hypertrophy, that is more suggestive of your inflammatory pathology, that will not be displaceable, and you will not be able to compress it, and it will be taking up the color Doppler activity. I have this video in my YouTube channel also. So later on, if you want to see, you can see there also. So see, this was the, something black, because your synovial hypertrophy also is going to be your hypoechoic most of the time, though it varies. It can be iso or hyper also, but more or less, it will always be hypoechoic. So see, when I'm trying to press with the probe, I'm able to compress it fully. See, fully I was able to, okay, I stopped it. See, it was just compressible. I was able to reach to all this, suprapatellar and the prefemoral fat pad, they were just aligned, right? So this means I'm just dealing with a simple fluid. And as you can see, the amount of fluid here is very less what we have seen in the previous video. So now, how are you supposed to go about doing an intervention for osteoarthritis? So osteoarthritis is always I should say, the short axis in plane approach, the best one. And you come from the lateral side and just inject. If you have a fluid here, it is a boon because your fluid is going to give a contrast to your needle, right? And you will be able to do the intervention very nicely. So you come from the lateral inside your targeted area. And what all you can inject here. So osteoarthritis, we are now not in favor of injecting steroid. So you can go for an injection of PRP plus hyaluronic acid, the synthetic one which is prepared, so you can go for that injection, and after a period of 1 month, you can go for the second PRP injection, and after a period of 1 month, you can go for third injection. Means you can give 3 injections and 1 month apart. This is what I follow at my center. But right now, there are no recommendations about when it comes to PRP. Different people are following different protocols. So you can even inject once in 15 days also, right? Some people have started injecting, after 1.5 months also. So it is up to you. If you ask my personal advice, I would advise you, because usually the healing takes place within 4 to 6 weeks. And though it continues further also, and that is the reason of me giving PRP after a month. So you can just do that. Second is your jumper's knee. We do call it as patellar tendinopathy. So this patients will be coming to you with a pain, which will be around this patellar tendon. And it will be getting worse after jumping, running, walking. Then what all you can see even the tendinosis. You might be able to see the tear. Treatment remains the same. Even if for a partial tear and a tendinosis, you go for a PRP injection inside the tendon. You can go for a longitudinal axis in plane or longitudinal axis out of plane. But if you ask my personal preference, is always short axis in plane, because it is just like, within a fraction of seconds, you are there and you will be able to see whole of the tendon very nicely. Fine. Now coming to prepatellar bursa. Another name for prepatellar bursa is housemaid knee or carpet layers knee. So housemaid, how they are just mopping the floor, right? So you are having a continuous friction there. And that is the reason you are going to have the collection inside the prepatellar bursa. Usually these patients will be having a pain which will be there over the patella. And if you happen to just scan these patients under ultrasound, this is how it looks like. You can go back to the recordings when you are seeing, and you can see how beautifully we have seen the normal one. So that is the reason I keep insisting that learn the anatomy, learn the sono anatomy first. And if you are very happy, if you have learned them very well, then any kind of abnormality in that particular area, you will be just able to catch it up very well. So this is prepatellar bursa. Now for bursa and for tenosynovitis, these are the only 2 conditions in your body where you are going to give local with steroid. You're not going to give PRP, because this is an inflammatory condition and we are not going to give another, thing which is going to cause inflammation. So otherwise this will be aggravating the pain of the patient. So if it is a bursa, what I do is I aspirate, I send it for analysis, and then I inject local with steroid. Ruling out the septic one. Septic one, how can you rule out? There will be the redness. This area will be just very hot and a tender to touch. Systemic markers will be raised. The patient will be having fever and all. So rule out the septic arthritis before injecting steroid, and which can be done clinically. Then coming to infrapatellar. So infrapatellar, this is also very important. This we are going to call it as clergyman's bursitis. This is more common in priests who kneel down and then they pray. And you happen to see the patellar tendinopathy, the prepatellar bursitis, and in fact, the superficial infrapatellar bursitis, this spectrum, 3 of them all together in one patient also, right? So you should know where exactly you are supposed to look for it. So this patient's will be having a pain somewhere here, right? So again, it's a bursa. So you can go for local with steroid, you can go in plane in the longitudinal axis, or you can go in the short axis in plane. You ask my preference, this is the one which I prefer. Because in this condition, the needling, it is very difficult. I do not want to trouble myself so much when the things are very easy. And that's the reason of me going for this short axis and in plane approach. Then this is how your superficial infrapatellar bursa is going to look like if it is enlarged. And this is how your deep infrapatellar bursa is going to look like. This I scanned recently only for one of my patient, right? So this is how your deep infrapatellar bursa is going to look like, right? And it is very easy. You have to just put it in the short axis, just go beneath the patellar tendon because already collection is there. And within a fraction of seconds, you will be able to perform the procedure. So that's all in the knee. Now, if you have any question, you ask me, or we will be just going towards the next topic for today. Any doubts in the knee? Okay, then let's see the nerves. So we will be just seeing the, we will be just learning the anatomy and the zonoanatomy of the nerves around the ankle joint. So the first nerve is your deep peroneal nerve. So before going into this nerves, let me tell you some important things so that it will be easy for all of you to remember these nerves. Now we have artery and we have veins. What are two veins? Two veins are your short saphenous vein and your great saphenous vein. What are the two arteries you will be seeing? You will be seeing the anterior tibial artery and you will be seeing the posterior tibial artery, right? Now, this is short saphenous vein. So this short saphenous vein will be having friendship with the sural nerve. Okay, here lights will not repel each other, lights will attract each other. That is the rule. So it is S. So this S will be attracting this S, right? So short saphenous vein will be lying adjacent to your sural nerve. Now here it is great saphenous vein. So great will again attract the great, the saphenous thing. So your great saphenous vein will be having the saphenous nerve along with it, right? Now anterior tibial artery will be lying next to your deep peroneal nerve. Fine. And the posterior tibial artery will be lying adjacent to the tibial nerve. Fine. So again, I'm repeating. Sural nerve with your short saphenous vein, saphenous nerve with your great saphenous vein, then your anterior tibial artery along with your deep peroneal nerve, and your posterior tibial artery along with your tibial nerve. Now there is one more nerve. This nerve feels so superior about it. Doesn't want artery and the vein. So this nerve is your SP, superficial peroneal nerve, right? Doesn't accompanied by any of the arteries, what we have listed, or the vein, right? So this is how, these are the 5 nerves which we'll be learning today. So this is your anterior ankle. So we have here the tibialis posterior, tibialis anterior. We have our extensor hallucis longus, extensor digitorum, and in some patients, you do see the peroneus tertius tendon also. So how can you remember the tendons also? I do not go with the mnemonics here because they are so confusing. Tom, Dick, Harry, and the medial side, things changes. Learn it in a very simplified manner. So this is your medial malleolus. Medial malleolus, you have one tendon here and one tendon coming from the back. The tendon which is coming on the anterior aspect will become tibialis anterior, and the one which is just beneath the medial malleolus, means posterior to the medial malleolus, it becomes tibialis posterior. Anterior one is tibialis anterior, posterior one is tibialis posterior. Now we have one great toe and then other digits. Okay, so great toe, we call it as hallucis when it comes to anatomical terms. And the anterior compartment is the extensor compartment. Medial compartment is the flexor compartment. So now one tendon should go to our thumb, to our great toe. So it becomes extensor because it's an extensor compartment. Hallucis because it is for the great toe. EHL, extensor hallucis longus. Now what all are left? Digits. So this is an extensor compartment. So it becomes extensor digitorum. Same way for the medial, you have a flexor hallucis longus and you have a flexor digitorum. Fine. Very simple. Now here you have this anterior tibial artery and this is your deep peroneal nerve. Now this deep peroneal nerve is the one which will be supplying all the muscles of your anterior compartment. Now muscles, you know, they are the extensors. So it causes the dorsiflexion of your ankle joint, right? Now what this nerve is sensory supply of this nerve. So this will be supplying the first interdigital cleft. Okay, so first interdigital cleft is this. Second comes our superficial peroneal. So this superficial peroneal is a nerve. So here is the nerve. You have the lateral compartment and you have the anterior compartment. So this nerve is at the junction, you should remember, okay, between the lateral and the anterior compartment. I think this nerve, I have a video also in my YouTube channel. You can just go back and watch there also later on once our course is over and you want to watch it again. So you have it in the lateral compartment and then you have the anterior compartment. In between these two, you're going to see your superficial peroneal nerve. And this nerve is the one which supplies the dorsum of the foot, except first interdigital cleft. Why? Because first interdigital cleft is supplied by your deep peroneal nerve, right? And this lateral portion. Why it doesn't supply this lateral portion? Because that is supplied by sural nerve. And on the medial side, up to the ball of the great toe. Why? Because that is supplied by your saphenous nerve, right? So superficial peroneal nerve will be supplying the dorsum, except the area supplied by sural nerve and the saphenous nerve and the deep peroneal nerve. Then this is your sural nerve. We have already seen it is accompanied by a vein. So that is short saphenous vein. And this will be the one which will be supplying the lateral aspect of the foot. Then we have the saphenous nerve lying adjacent to the vein. And this will be the one which will be supplying the skin up to the ball of the great toe. Then the tibial nerve. Now remember the tendons. We have tibialis posterior, we have our flexor digitorum, and we have flexor hallucis. This is your tibial nerve, and these are the tibial vessels, artery and the vein. Now this tarsal tunnel, I will just specify a little more because this is what is our pain physician's domain. Because if you see a patient of tarsal tunnel syndrome, which is just the entrapment of this tibial nerve in the tarsal tunnel. Now, what is tarsal tunnel? This whole area, we are saying it as tarsal tunnel because you have the medial malleolus here. This is the calcaneum and this is the flexor retinaculum. Now, what it has done, just like the carpal tunnel, there were bones. There is one retinaculum which has come on the top and has converted this into an osteofibrous tunnel through which the structures are passing by. So if you happen to see a patient of tibial nerve entrapment in the tarsal tunnel, so tibial nerve is the one which will be supplying the sole of the foot, right? So sole of the foot, if the patient is having some kind of tingling sensations, right? Think of an entrapment of tibial nerve. What all can cause the entrapment? You can have the tenosynovitis of your tibialis posterior tendon. Recently, I have seen one, okay? And then you have this FHL, because again, it's a tendon. You can have the ganglionic cyst. You can have the varicosity of the veins, right? You can even have osteophytes, which will be just coming and poking there, right? As a spur. So all these things are very important when you are evaluating, right? Always look for the tendon. When you are seeing the tendon, try to look for the anechoic collection around the tendon. So the treatment will be according to that only. So what you should do if you happen to see a tibial tenosynovitis, posterior tibial tendon tenosynovitis, then you are gonna inject local with steroid there and do a hydrodissection of your tibial nerve. definitely this is going to relieve patient's pain like anything. Okay. So you treat according to what exactly you are seeing. So this is again a revision. First interdigital cleft supplied by deep peroneal nerve, dorsum of the foot supplied by your superficial. This should go till here. So this is your saphenous nerve. Okay. This is your sural, and the whole of the sole of the foot will be supplied by your tibial nerve. Fine. So we'll see the demonstration of what we have learned now. If you have any question, you can ask me. So let me adjust the Mali. So now the same position of the patient. Let me adjust the camera a bit. It's really fine. Okay. So now we'll be seeing the deep peroneal nerve. I will change the probe. Now we'll go for 20. Okay. Change the setting also. I want ankle down. Okay. So in order to examine the deep peroneal nerve, he's lying down in a supine posture. Knee is flexed. Fine. Now I'll just give you tips for everything so that it becomes very easy for you to identify. So knee is flexed, and as you can see, the foot is resting on the table. So what you are supposed to do, put your probe in the short axis to the shin of the tibia with the aspect marker. Okay. So you put your probe in the short axis to the shin of the tibia with the aspect marker towards the lateral side. So once you are doing that, you will see, okay, my annotations are on. Once you are doing that, you will be able to see the tibia in the short axis, something like this. Okay. Now, what is your main aim? To make this inverted U, make it flat. Okay. How can you make it flat? Just keep moving down. It will become flat. And then rotate your probe towards this side. Once you are doing that, you will be able to see the structures nicely. So I'll just show you. So this is your, because it was pulsating, that is your artery. Now this is your nerve here, right? Now, if you want to look for the tendons, I'll tell you again a very nice way to see for. So this is our anterior tibial artery. This is our deep peroneal nerve. This is what we are seeing. Flat thing is the tibia, the distal end of the tibia, right? To learn the tendons, one by one, I will show you. So I'll bring my machine a little closer to me. Now it will be fine. Machine was quite far from me. So what you are seeing here, this one, this is tibialis anterior, right? This tendon which you are seeing, the biggest one, that is tibialis anterior. From there, if I am moving and if you are confused what exactly you are seeing, you don't know. So if you want to see the EHL, what you can do is you can just, move this toe. So you will be seeing that there is a movement in, one muscle. So this muscle, what you are seeing here, this is your EHL muscle belly and that is the tendon. And what you are seeing here, that is your extensor digitorum. Fine. So this is how you identify the tendons. So start from here, tibialis anterior, go to this side. You are going to have your muscle belly along with the tendon. Then you have your extensor digitorum. Extensor digitorum will be having the aponeurosis on its top. Muscle belly will be down and your tendon will be forming from its superficial surface. So that was about the deep peroneal. Now you put lots of jelly because now we will be seeing the saphenous. So in order to see the saphenous, apply lots of jelly. This is your medial malleolus which you are seeing here, right? So put one of your finger there, put lots of jelly and just very slight pressure, okay? So once you are just applying a very slight pressure, what you will be seeing? You will be able to see this great saphenous and adjacent to that will be your nerve, right? Now I'll show you the superficial peroneal. Mali, ऐसे करके बैठ जा. Okay. So for that, this is your lateral malleolus. Okay, go 4 plus 2 fingers up from here, depending on the width of your finger. Again, put your probe in short axis with the to the fibula with the aspect marker towards the lateral side. So 4 plus 2, 6. I'll keep it somewhere here. In the short axis, so the moment I am going to do this, I will be able to see something like this, right? So I'll freeze it here. This is the short axis of the fibula. This is peroneus brevis. This is peroneus longus tendon. This is your superficial peroneal nerve. Okay. This is your extensor digitorum. This is what we have learned. This is the tendon of the anterior compartment. This is the tendons of the lateral compartment. So that is how you look for the superficial peroneal. Now, if you want to look for the sural, right? What you are supposed to do? We will so let me show you, or I need to show you from here. So this is lateral malleolus, and that is the Achilles tendon, this border which you are seeing. We'll keep our probe between the lateral malleolus and the Achilles tendon. Fine, like this. Once you are going to do this, you will be able to see the short saphenous nerve. Always remember this will be in a sling like this. This was the lateral malleolus side. This side was the Achilles tendon side because you are able to see the tendon of your peroneus brevis and the longus. This is in the subcutaneous plane lying adjacent to the vein. Fine. So that was our sural nerve. So quickly I will repeat. Probe is in short axis. We are seeing the. So this is for the superficial nerve, right? Lying between the extensor digitorum and the peroneus brevis and the longus. Fine. From there, if I'll go down, go to this side, you will be able to see short saphenous vein and the sural nerve there also. Okay, because then it comes down. So you can see it from there also. This is superficial peroneal nerve, like how in the forearm we see the, I should say, the median, the ulnar and the superficial radial nerve in one go. So here also you can do that. If you don't want to go there, you can see it here also. So that is superficial. You slide your probe to the posterior aspect. You will be able to see the sural nerve lying adjacent to the short saphenous vein. Okay. Deep peroneal we have seen, saphenous we have seen. Now tibial I will show you. Mali, idhar hoke suno. ऐसे रखो. So this is medial malleolus. You have the calcaneum here. So you are supposed to keep your probe like this. If you will keep your probe like this, you will not be able to see the things very nicely. So we will keep our probe with the aspect marker over the medial malleolus because we know this is medial malleolus, that is calcaneum, and we are supposed to keep our probe in an oblique manner. So the moment I am going to do, I am going to keep my probe like this, I will see something here. So let me reduce the depth, increase the gain. Okay, so now you will be able to see it nicely, I think. I will go to the virtual convex so we can get a big picture of it. Okay. So concentrate here. I will be showing you how to make use of the anisotropy to see the tendons, right? See, you're able, I'm making use of the anisotropy to look for this tendons. Now, this is your tibialis posterior. That is your extensor digitorum. That is your artery. This one which you are seeing is your tibial nerve. This is your FHL, which will be having a muscle belly here. And that is your flexor retinaculum. So tibialis posterior, extensor digitorum, tibial artery, because I have compressed it, so we are not able to see the vein. This is tibial nerve. And this is your FHL, which is having a muscle belly. Sometimes for this patient, in the extensor digitorum also, I am able to see a muscle belly, which is there, right? So these are the tendons. This will be going for the digits. This will be going for the thumb. That is your artery. So I think that finishes your demonstration. Now, if you have any question, you can ask me. Not, then I will ask you. Any question? No question?
Ma'am,
Okay.
could you please demonstrate the procedure of giving a PRP into the for osteoarthritis? Can you show that again?
Okay.
With landmarks, ma'am.
With landmarks, I don't follow the landmark techniques.
Okay.
I give USD guided. I have a USD
Okay, ma'am.
machine.
Yes, ma'am. I mean, where to
No.
put the probe, where to place the probe, all that.
Have you seen the sonoanatomy demonstration?
Yes, yes, ma'am. Yes, ma'am.
Okay. Okay, I'll do one thing. I'll adjust the camera again because Mali, just give me 1 minute.
Okay, sure.
So are you able to see the screen? Who asked me
Yes,
this?
yes, ma'am.
Saurabh?
Yes.
Saurabh asked me. Who asked me this?
This is Pratyush.
Pratyush. Okay, Pratyush. So we have already seen the, I should say, how our, okay, let me, the depth, increase the gain, little more depth. Okay, this is fine. Yeah. So this is how we have, okay, why my screen has got stopped. What's wrong with my screen? Screen काम नहीं कर रही है. Just give me a second. I don't know why my screen has stopped. Just 1 minute. ठीक है. Okay, now I think it is moving. Freeze, yes. So we have kept our probe like this. Okay, we try to identify it in the longitudinal axis. But longitudinal axis is not the best one to go for any kind of intervention. You need to come to this recess. This recess is present between your suprapatellar fat pad and this is your prefemoral fat pad. So you are supposed to identify it in the short axis. So for short axis, just rotate your probe. Once you have rotated your probe, I'll give you a tip from my experience. Okay, this I have. Okay. So now when you are keeping the probe, you keep your probe exactly here and then keep on coming down until you see something which is hanging down from this quadriceps tendon. So this is quadriceps tendon. Now this thing is hanging down from it. So that is your suprapatellar fat pad. Okay. And beneath that only you are going to have your suprapatellar recess. Okay, you see it once again so that you don't miss. It is not there in any of the books. This is, I'm telling you from my experience. Okay, so you keep on scanning down, down, down. So now you know that this is your suprapatellar fat pad, right? So I will freeze it here. Okay. Now, if you want to go for an intervention, so this is the recess where you are supposed to come, right? Now, how our probe was? Our probe was on the lateral side. This is medial side. So you are gonna, if this is your probe, right? From the lateral side, you calculate the depth of this recess. Now, the depth of this recess is approximately 2 centimeter from the skin, right? So if this is your probe, right? Okay, let me stop this and show you here. Okay, so now it will be visible to you nicely. So if this was our probe, we have identified that your suprapatellar recess is located at a depth of, approximately 2 centimeters from the skin, right? So if this was the skin, I will calculate 2 centimeters from it, right? And I will go in plane. That's all. It is that easy to inject here, right? So again, you see this. So now just correlate it what I have taught you. So this was the skin. This was the skin. Okay, you have calculated the distance till here. You will come from the lateral side and you will inject here. And you will see that it has started, widening up. Okay, but the position is also very important. Got it?
Yes, ma'am. Thank you, ma'am.
Okay. For in plane, it's always good. You calculate the distance from the skin if it is your structure is exactly there. So it will be very easy for you to go inside.
Okay, ma'am.
Any more questions? No questions? Everybody has understood everything? That's good. Okay, then, if there is no question, we'll call it a day off. And we'll see in the next class. Next class, we will be learning the zone anatomy of the lumbar spine. Till then, keep reading. I'll be posting the articles. And you go through the articles. And if you have any doubts, you can ask me in the next class. Okay, take care and bye-bye. Good night.